So with the multiple symptoms of BPH in mind, we can transition into the multiple treatments that are also available. So walk me through what we typically see with patients, and then also the BPH journey, so to speak, in terms of how we can treat a patient or improve their quality of life.
Yeah, so I think it goes back to the prostate and the prostates, the size of the prostate, small, medium, and large prostates, and then the same way the symptoms are a bit of a spectrum. They kind of start as kind of mild, moderate, and then severe urinary issues, and so the treatment can kind of parallel what the symptoms are. For certainly people with mild symptoms, taking a herbal like saw palmetto or medicines like this can be helpful. The studies are kind of 50-50 on that. Some people say it helps, some people say it doesn't really help. It may actually depend on the quality of the product, but for mild urinary issues, I think taking a saw palmetto type product can be helpful. Reducing coffee, cokes, teas, things like that can be helpful. Bladder irritants and all, the reducing those can be helpful. But then when those fail, for decades we've had medicines like Flomax or tamsulosin, uroxetrol or alfuzacin or finasteride or Proscar, and these medicines have worked great, and we've used them for decades. I've prescribed hundreds and maybe thousands of these prescriptions for my patients. The only thing is that we're starting to realize is that all medicines have effects and side effects, and when it comes to some of these medications, they can cause nasal congestion, they can cause fatigue, they can reduce your blood pressure, they can cause retrograde ejaculation, meaning to say when you ejaculate, some of the fluid hiccups back into your bladder and you have a diminished sensation of orgasm. So they're not benign. With the finasteride or Proscar, or that little blue pill, that one actually blocks conversion of testosterone to dihydrotestosterone, and that can have significant issues on libido, erectile dysfunction, ejaculatory function, depression, fatigue, you name it. So there's some bad stuff that can happen. Not to mention all these medicines have copays, $15 to $30 a month the last time I looked. So you can be out a couple $100 a month just paying for these medicines for the rest of your life. So yeah.
And to add to that, one of the common misconceptions is a man comes to you, talks about their prostate problems, and then you put them on a medication like Flomax. But the thought is, once you respond to the medication, this is something that you're going to essentially end up taking for the rest of your life, right? Because these medications don't really aim to cure or solve the source of the problem, rather they treat the symptoms.
Right.
And so it's very common that we'll see a male in their 70s or 80s, and you look at their medication list, and Flomax has been on there for the past 2 or 3 decades. And when you ask them about it, the medication, they'll tell you, oh yeah, I take it just like a vitamin every day. It's one of the many pills that I take. But that is something that we commonly see. Guys think you can give me a pill and this will fix everything. When reality is more of a band-aid or kind of a temporary fix that treats the symptoms. Whereas the main issue with BPH is the prostate continuing to enlarge or obstruct that urinary channel.
Right, and it doesn't fix the problem. It is a band-aid, and it's a band-aid you have to keep on for the rest of your life. And the second you forget a dose or forget to take your pills, you're going to be in trouble, within a day or two of stopping the pill. So if you go back, historically, you had the medications, and Flomax was a game changer for a lot of patients. But the thing is, if the Flomax didn't work, or you didn't want to take the pills, or you had side effect from the pills, what did you do next? You went to the TURP or Roto-Rooter historically, and I've done hundreds of those procedures, but it's a procedure you do under anesthesia. You go in through the urethra, you carve out a lot of that prostate tissue and evacuate it. But what are the side effects of that? It's at least an hour and a half procedure under general anesthesia typically. It is strongly correlated with retrograde ejaculation, which is permanent. Sometimes some erectile dysfunction, which can be permanent as well. So there's some real side effects or downsides to the TURP. And that's where the Urolift has really been a game changer, because it gave someone who didn't want to be on medicines anymore, didn't want the TURP or Roto-Rooter, but wanted something in between that didn't have the side effects of either the TURP or the medications. They now had an excellent option.
Right. So instead of instead of jumping from point A to Z now, you have A, B, C, D, you know, in between to kind of help somewhat act as a stopgap between the two. And a lot of the times, treatments like the UroLift may just be where patients stop at. That's all they really need in terms of their BPH treatment.
Right.
And so regarding the UroLift system, give us a brief overview about what that entails and, you know, how, let's just say if I were a 60-year-old male coming into the clinic today and this is something I was interested in, what is the process like?
So the UroLift procedure has been done for over 6 years now. We've got data on nearly 200,000 patients worldwide. So we've got outstanding safety data. There's no reports of erectile dysfunction, ejaculatory dysfunction, or anything like that, which is outstanding. I started offering it to my patients about 3 years ago. Anytime there's a new technology that's available to us, I'm always a little skeptical about it, just because these technologies can be good or they could be not good, and we could find out you know later on down the road, wow, we thought it was good but it's not. And so for the first 3 years it was available on the market. I did not do any of the implants, but what happened about 3 years ago, I started offering this to some of my really high-risk elderly patients who couldn't undergo a general anesthetic. They were on blood thinners and I couldn't do the TURP. So I said, hey, there's this new advanced device called the UroLift. So I started doing that on my high-risk patients, and I started noticing how well they were doing. And once I started looking at how well they were doing and then looking at the safety data, I became more and more of a believer on it. Then beginning last year, we started offering it on more and more patients who were qualified. And now in this third year of me doing them, we are now broadening our exposure of the number of patients that we do this to, and really trying to get people off of medications whenever it's acceptable and possible, and doing this one-time procedure and getting them off hopefully a lifetime of being on pills. Now, having said that, not every procedure fits every patient, and you have to tailor the procedure to the patient. So there are indications where the bigger the prostate gets, i.e. if it's over 80 to 100 grams, so typically over 80 to 100 grams, there's a procedure that you do, the HOLEP, which I think is very appropriate. But patients that have a prostate size that's smaller than that don't have something called a median lobe, are a very good fit. Now, to answer your question, what we do when a patient says, hey, this is something I might want to do, we do the American Urologic Association Symptom Score Index. So we qualify how bad their symptom scores are, just to understand how a day of their life looks like with urination, number one. Number two, we do a post-void ultrasound, so we scan the bladder after they urinate. So how well are they emptying their bladder? Are they retaining a lot of urine, some urine, or no urine? Third is we do something called a urocuff. I call it like a blood pressure cuff on your penis, but we basically urinate through that, and it gauges the force and strength of urination. And patients who are very good candidates for UroLift, they're generating high bladder pressures to generate very, very little flow, where it really should be low pressure, high flow. Now it's basically high pressure and low flow. And the danger of that is, and we were just talking about this, the longer and longer your bladder works harder and harder to squeeze to empty the urine, there's ongoing damage happening to your bladder. And to investigate for that damage, then we do something called a cystoscopy, which is a quick 30-second look into the bladder that we do here in the office. We use some local anesthetic to do that. We've got the latest high-definition digital camera systems to evaluate that. So we take a look. And once we kind of check all those boxes and make sure you're an appropriate candidate, that's when we say that it's okay to proceed with the UroLift.
So the evaluation is very thorough, and there's multiple parts of it, but in reality, it sounds like is this going to be 5-10 visits to the office just so we can kind of figure out what it is we need, but in reality, it's 1 or 2 visits, and within a week or so, we typically have a pretty good idea or plan set aside for every single patient that's tailored to what their needs are.
Yeah. And
between those 2 visits, we usually have something set in stone that fits that patient, and we'll be able to take care of them.
Right.
Now, so I'm set up with the UroLift. I've been determined to be a good candidate for it, and I'm walking into the office today for treatment. What is my day going to be like?
So there's two options to have the UroLift done. One is in the operating room under a general anesthetic. If that's the case, it's easy enough. It's lights out, and it's about a 45-minute case, and we wake up and you're done. The downsides of that is it is a general anesthetic. For some people, that's a big deal. Other people, not really. And then number two could be a cost factor in terms of what their out-of-pocket is for insurance. The brilliant thing is the UroLift is actually simple enough that it can be done on a number of patients here in the office as long as they, again, fit our appropriate criteria. And typically, I would say in our patient population, about 80% of our patients, fit the criteria that we can do that procedure here in the office.
Excellent. And I get the procedure done, everything goes smoothly. What are some things you would tell me to expect after the procedure, and how long would I expect them to last for?
Got it. So, again, as you were just asking, leading up to it, hey, are you going to be, in the operating room or at the office? If it's done at the office, typically we ask our patients to take a Xanax pill just before the procedure, and that's an anxiolytic just to kind of, ease your nerves just a little bit. The second thing that we offer is nitrous oxide, so it's an inhaled gas, and it basically relaxes you. I would say it's sort of like, my patient described it like having a light beer or something like that, just kind of an easy, sedative, and it's over, using an inhaled mask breather. And the brilliance of it is that you breathe that off within 15 minutes of the procedure, and you could, and you're good to go. And so it's rapidly reversible. On top of that, we inject local medication, lidocaine, into and around the prostate to numb up the prostate. And then finally, we use lidocaine jelly in the urethra itself. So we call it multimodal anesthesia. So we use multiple routes to just kind of relax you. And the procedure itself is probably about 7 to 10 minutes. So it's really by the time you're in and out of our office on that given day, about 45 minutes to an hour have passed. A lot of that involves the pre-procedure and then the post-procedure process. But the UroLift, the brilliance of it is it's literally about 7 to 10 minutes. And what I tell my patients, it's like going to the dentist's office. It may not be the most pleasant experience. It's a little uncomfortable. Getting that lidocaine injection may be a little uncomfortable, but then it all goes numb, and if you can just kind of put up with it for about 7 to 10 minutes, it's over.
Gotcha. And after the procedure is done, what are a few things I should be expecting in terms of side effects, things to worry about, things to watch out for?
Okay. Yeah, and using our protocols, about 90% of our patients will not need a catheter. In fact, we will give our patients a catheter if they need to self-catheterize at home. But the brilliance of this is a lot of patients really dislike the Foley catheter. They don't want one. So if we can at all avoid it, we will not put a catheter on a patient. Only if I feel that there's any bleeding or swelling or anything that I'm uncomfortable with, I may place a catheter in about 10% of patients, and then they just come back the next day to remove it. Afterwards, patients will experience some kind of urgency and frequency of urination. They may have a little bit of burning with urination. They may see some small clots in the urine or a little pink or red colored urine. That can be common, but typically I'll see that will resolve within 24 to 48 hours. Indeed, I tell my patients who are golfers, if we do this on a Tuesday or Wednesday, could they be doing their chipping and putting on the golf course by that weekend? Yes. And in terms of pain and discomfort, we do give narcotics to our patients. I tell them if Tylenol or Advil, does the trick. I think in a lot of people, that's all that they may need, and they may not need any narcotics or more aggressive pain medicines beyond that.
Excellent, excellent. And when we talk about UroLift and kind of where it fits in with the whole big picture of treating BPH, we've established today that it's a very good bridge between medications and conservative therapy to bigger surgeries like the TURP or the HOLA. One thing that we've also haven't mentioned too is that just because the UroLift gets performed, it doesn't necessarily preclude you from having another procedure down the line in the event you do need it. Is that correct?
Right, yeah, and that's a brilliant thing is that patients have asked me, well, what about the clips also, by the way? And it's a stainless steel clip on one side and a nickel titanium clip on the other side. I tell people these are the same things that we use in appendix surgeries, gallbladder surgeries, hip and knee surgeries, so it's the same surgical steel. or nickel titanium that's widely used. It's literally a tiny little clip with a surgical suture in between. So, and having said that, foreign body reactions or allergic reactions to this are exceedingly rare, number one. Number two is that, for sure, if at some point you realize, hey, maybe 10 years have passed and I want to consider a different procedure, I need a different procedure, you can always actually remove the clips and the clips can come out. So that's the brilliance of it. So it's a procedure that doesn't preclude you getting other things done down the road if you need.
Awesome, awesome. And so to kind of wrap things up and summarize what we talked about today, we briefly touched on BPH and what that entails. And we've mentioned that it's not a one-size-fits-all treatment for BPH, and in terms of all the options that are out there, Urolift is one of the most innovative and widespread and safe procedures that can be done either in the operating room or in the clinic.
Right.
And in our practice, whenever a male comes in to talk to us about any prostate issues or BPH, Urolift is definitely a very good option after we've done the full workup and the evaluation.
Yeah.
Any other things that you feel like the guys out there should know about Urolift or BPH today?
Yeah, the one last thing I want to mention is the prostate does continue to grow with age, and again, it depends on your genetics. And there's, if your dad and your grandfather had enlarged prostates and you're predisposed to that, your prostate may grow faster than other people's prostates. Same thing where some people need haircuts more often than others. So based on the data, the worldwide data on Urolift, we have excellent 6-year data. Meaning to say is that the improvement in urination, which is nearly 50% improvement in urination with the Urolift 6 weeks after the procedure is done. So 6 weeks later, you get off all the pills, and there's a 50% reduction in urination symptoms. The data suggests there's a 6-year durability of that. Okay, meaning to say that once you see that 50% reduction, it'll stay there for 6 years. Now, we don't have 10 and 20-year data because the procedure's not been out for that long. But having said that, what I do tell my patients is that if you do the Urolift, there's a relative warranty or guarantee that for the next 6 years, you will not need another procedure. And at 6 to 10 years, if your prostate continues to grow, we can always reevaluate. We can put additional clips in. We can take those out and do a more invasive procedure if needed. So it really doesn't burn any bridges, and it doesn't have all those sexual side effects. So again, if it's you fit the demographic and you fit the criteria that we discussed, I think it's a wonderful procedure.
Awesome. Well, thank you, Dr. Shaw. And this concludes our video on Urolift today in BPH. If there's any other questions, please reach out to our office anytime. Or if there's any questions regarding your overall health, feel free to reach out to us or to your primary care doctor. Tune in for more videos regarding BPH, men's health, and all things urology related. Thank you.
Thanks.
Like and subscribe.